Welcome to Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Ol Unar, and my guest today is Dr. Jeff Pettey. Dr. Pettey is the Dr. Ezekiel R. and Edna Wattis Dumke Endowed Chair for Global Outreach, Vice Chair of Clinical Affairs, and Professor of Ophthalmology and Visual Science at the John A. Moran Eye Center at the University of Utah, and I'm so excited to have him on the podcast today. Dr. Pettey, thank you again for joining me.
Oh, thank you so much. This is an honor. Really excited. Fun topic, exciting to talk about on a number of fronts, and an honor to be invited.
Thank you so much again. And let's delve right into our case. We have a 75-year-old woman who presents to your clinic with progressive blurry vision in both eyes. Visual acuity is hand motion in the right eye and counting fingers in the left eye. Your anterior segment exam is unremarkable except for 4+ nuclear sclerosis with uniform brunescence in the right eye and an intumescent white cataract in the left eye. There is a poor red reflex in both eyes. You perform a B-scan ultrasound of both eyes, and that is unremarkable, and they're interested in cataract surgery. Dr. Pettey, what questions would you like to ask this patient to decide your surgical plan?
Yeah, I'm smiling just thinking about this case. These type of advanced cataracts can be really, really rewarding for patients with this level of vision. So you want to know, what's happening in the past. Has she had any history of trauma? Any family history of cataracts? History of things like pseudoexfoliation, glaucoma? Really, anything that might add to the complexity of the case. If you have a case where the only kind of complexity is a dense lens or a white cataract, that generally can go quite well, even early on in your career. But it's when you add in these other complexities to the case that things might get a little more challenging than you had expected.
And could you tell us the different types of non-phaco emulsification cataract surgery that we have available? How are they different from each other and to phaco emulsification?
Yeah, it's such a great question. So, viewers can't see me. I'm not that old. I finished residency around 2011, 2012. So, despite some gray in my beard, you're not talking to someone who grew up in the era of an extra cap. So, extracapsular cataract surgery is delivering a lens with an opening in the capsule. Phaco is actually considered a form of extra cap. So, you have phaco extra cap, and then you have a manual extra cap. Manual extra cap, I think of as like open abdominal surgery. You're going to open that whole thing up and deliver everything out. Whereas phaco is a little bit more like a laparoscopic surgery, a couple small incisions, put your instruments through those. So you have to have a wound that's large enough to accommodate the lens. The lens can be as large as almost an M&M, and that's something that, again, requires a wound that you can deliver that through the side of the eye. That can be done either through the clear cornea with sutures. That can be done through a modified incision, which, believe it or not, you can deliver the whole lens out and have zero sutures, have it sealed perfectly. That's generally called small incision cataract surgery. And finally, if you go back a long, long time, there's something called intracapsular cataract surgery, where you deliver the entire lens and capsule in one piece. Again, this requires the largest of all the wounds because you deliver that whole. Again, that's rarely ever seen or done, although just did one a couple weeks ago. And for someone, let's say in a high-income country where phaco is what you're going to train on, you may never see a manual delivery of a cataract, and you would generally approach complex cases with phaco because that's going to be how you were taught, and that's what you'll know.
I think that's such an important topic to bring up, regarding the different training requirements. And in an experienced surgeon's hands, I think the length of the procedure can be a determining factor. How long is each procedure if you're experienced, and how do these differ than a experienced phaco surgeon?
Yeah, around the world right now, the dominant surgeries are phacoemulsification now, and this small incision extracapsular cataract surgery. I'm going to give it another name because the incision you make in small incision is 6, 7, sometimes 8 millimeters, which is rather large to those of us who grew up on phaco. So a lot of people call it a sutureless extracapsular cataract surgery. And I'll refer to either SICS, M6, or sutureless extracap throughout. How long do they each take? Well, it depends. In the most experienced hands, you will see in your training program surgeons that, just consistently do sub 10-minute phacos. And that's really beautiful surgery, some even faster. But again, in kind of lovely, beautiful, elegant hands, that's pretty consistent benchmark. And for sutureless extra cap, you can have times that are actually a little bit faster in my experience. Now, that is in a true expert hands, meaning there are centers around the world where they are doing 60, 70, 80 cataracts in a day. The only way you can accomplish that is if you're doing really efficient cases. And I do stress efficient, not fast. For you in training, if you are trying to operate fast, you will have some long, ugly cases with poor outcomes. Operate elegantly and efficiently. And that's where you find these really impressive efficiencies, whether you're doing phaco or sutureless extra cap.
I think that's a very important point to bring up. We did mention intracapsular cataract surgery, which you said is rarely performed nowadays, but I think really important in our understanding of modern techniques. What are the indications and some key steps of intracapsular cataract surgery?
Yeah, I mean, 50 years ago, give or take, the indication was someone who had a cataract that needed it removed because that was the technique that we had at the time. And so that again is a large, large incision, really almost, 6 full clock hours of an incision. You basically lift the edge of the cornea up at the limbus like you would the hood of a car. And then you remove the entire lens. Now, there's a few different ways it was done. Zonules, when they're really strong, create a barrier to removal of the lens. So there were techniques to lyse or chemically dezonule the lens. That's with alpha chymotrypsin. Once the zonules were weakened or removed, you could remove the lens via a number of techniques, but the most common was through a freezing technique with cryo. So you've got the hood of the car up, the zonules are now released, and you take a cryo probe, place it right on the lens, freeze it. That creates the old effect of putting your tongue on a frozen flagpole, basically adheres, and you pull that whole lens out. And then you've got a lot of elegant suturing to do if you want to leave someone with good vision after that, because, of course, that many sutures would induce a fair amount of astigmatism.
Why don't we do this surgery anymore? Like, what are some complications that are unique or seen more often, especially compared to phaco, for example?
Yeah, it's a higher risk surgery. Again, think of general of surgery evolution. An abdominal surgery. You used to open up, from pelvis up to the rib cage initially to gain as much access as possible. Then incisions came smaller, and then came laparoscopic. That's the same evolution that we've had in cataract surgery. With you can imagine if you're removing that entire lens whole, if you do have some adhesion between the vitreous and the lens. You're going to increase the risk of retina detachment, increased risk of CME, increased risk of endophthalmitis. And with each of these iterations, again, smaller incisions as we've gone, and then the eventual from intercap to extracap, where you're going to leave the capsule in place, leave the zonules in place, right? The springs on a trampoline, and that creates a natural barrier to keep vitreous back where it belongs, and again, just leading to less overall complications.
And speaking of that, let's shift our focus to the extracapsular variants, including M6. Who is the ideal candidate for these procedures? And you briefly mentioned what ocular findings and history would make these more challenging. But what do you generally think of when you have a patient right in front of you?
Yeah, the answer is going to be primarily for U.S. trained surgeons. What can you do to get this lens out safely? So if you train, I 100% phaco, didn't see an extra cat my entire residency program. So as I'm leaving residency, the only tool I have, every cataract, phaco was the indication because that was the only thing I could do. And that's going to be, again, nearly all of us. And so if you do go through the process of really becoming a student, getting a mentor, typically it involves, again, similarly, hundreds of cases, just like it did to become competent at phaco. Then all of a sudden you're gonna have that as an available skill. And for me right now, phaco's still writing right-handed. I'm just a little better at it than I am SICS. SICS I can do, but it's still just a little bit less natural for me. Whereas if you grow up training in a lot of parts of the world where you do 500, 600 SICS before you do your first phaco, that SICS is going to feel like your go-to for almost any dense hard lens the rest of your life. So forgive the long answer, but for someone who has both skills, relatively adept at both, the denser the lens, the more likely SICS is going to give you a better outcome in the short and the long term. You can also discuss a little bit about zonules and whether, with zonulopathy or other things such as corneal opacity, which is going to give you the best result. And again, I think that answer mostly comes down to how good are you at each. Whereas the density is one you just can't get away from. Again, 2 weeks ago in Dodoma, Tanzania, a pure black cataract, zero light getting through, and again, pulling this lens out, phacoing that would have been a far worse outcome than this beautiful, elegant SICS that we did with our partner there, delivered this out less than 10 minutes, and the patient's cornea was crystal clear the next day.
And I think those surgeries are really a testament to the amazing training and experience that is provided around the world. I still remember my very first M6 case that I did in residency. It's very amazing. And so, speaking of, what are the key steps of extracapsular cataract surgery, and what intraoperative pearls do you have for our listeners who might be performing this procedure?
The key step the key step is going to be creation of a self-sealing wound. I've with several of my residents who are, relative, maybe a couple hundred cataracts in, we've got a great candidate patient eye for SICS. I will create the wound because once that wound is created and it self-seals with this internal valve, at that point, accessing the lens, either with a large CCC or some other technique, that's not technically terribly difficult. In fact, every resident hydro dissects lenses up into the anterior chamber unintentionally throughout their training, and that's actually a really great way to get it up out of the bag. Is make a large CCC, put in some fluid behind it. All of a sudden, the lens is in the AC, and if that lens is well constructed, adequately sized, there's many different ways to get that lens out of that incision, but you can take a lens loop, you can modify a needle into a hook, you can use irrigation fluid behind it, you could use an anterior chamber maintainer and then push the lens into that funnel. Any technique is going to help you get that lens out of the eye, with that scleral tunnel being the key foundational step of the entire surgery. Pearls for making that, well, I mean, this is actually one technique that has a really nice surrogate. You can use an animal eye. An animal eye sclera is really bioidentical to ours, other than the thickness. And you can do on a single pig eye, a goat eye, you name it, you can do 3 SICS wounds over and over and over, and per eye, and that's going to actually give you a lot of that muscle memory you need. There are some models out there which have some utility, but none of them can help you make that wound the way that something like a pig eye would. So if you really want to learn this, you really have to get a mentor, take some wet labs, and then just get as many reps as you can making that wound. Once that wound is created, I've handed things over to residents, said, all right, you show me how you would get this out. And in case after case, they find a way to deliver the lens out, do bimanual IA because we got our phaco machine sitting there, and deliver a really beautiful result to the patient.
That's awesome. And you really focused on the importance of the incision. What do you think about when someone is getting prepped? Like, how do you think about the anesthesia? How do you think about the capsulotomy? You did mention, that it's important for it to be large, and some other pearls regarding potential IOL insertion.
Yeah, general theme you're going to hear, use the skills that you have and just modify them in a way that helps you. So I'm just going to touch on capsulotomy, different ways that you can do a capsulotomy. Some people do what's called a V, where you go in and you, with a cystotome or a needle, you basically create a V with the apex toward you at that main wound. And then you just, again, lift up the hood, a proverbial hood of the capsule, and then you access the lens that way. You can do a can opener. That's certainly a way to do it. You can also do an envelope, which when you see this in a video will blow your mind. Imagine taking a keratome and just sticking it in that proximal part of the anterior capsule and extending an envelope opening to the right and the left, and then just delivering the lens straight out that way. So for phacosurgeons, you're going to be comfortable with CCC. That's what you're going to do. You can make a big one. That's going to be your great place to start. But things that I think about at the beginning of a case: anesthesia. This is one where you do, if you're more comfortable with blocks, do a block. Do a block, do a block. You'll get a little better eye movement control, a little better anesthesia as well. Um, you certainly can do these under topical with just a little bit of subconjunctival lidocaine. That works very well for the anesthesia, but of course, you just don't get the paralysis for that. Things that become increasingly important are the anatomy of the brow. If you're using a superior approach and you have a deep set eye, I'd recommend doing a block just for the sake of a little volume in the orbit to bring that forward. People operate either superiorly or temporally. If you train temporally as a phacosurgeon, you're always going to feel a little more comfortable temporally in SICS. That's what I do. And again, the building blocks that you've built in your residency training are the ones that you're really going to take to get to deliver the best results for these patients.
I think the superior positioning, as you mentioned, feels really different when we initially start. And I think having that experience with other procedures like glaucoma, I think really makes the superior positioning a little bit more comfortable.
Yeah, it's
And
a perfect point. Perfect point. Again, it's what you are bringing to the table as you're learning this. One little aside: if you ask a phaco trained surgeon in the U.S. who's just gone and spent some time doing SICS, which is more difficult, they're almost universally always going to tell you SICS is the more difficult surgery. But if you take trainees from India, Nepal, they're 500, 600 SICS in, and they're doing phaco, they will tell you phaco is the far more difficult surgery to learn on. So there's something really interesting about the fundamental building blocks we have in our early cases that we learn that really set us and set a lot of our tendencies and our levels of comfort well into the future.
And speaking of the different experiences that surgeons have, what is the expected course of recovery for an experienced person for extracapsular or M6? And how often do you follow these patients compared to a patient who you performed phacoemulsification on?
Corneas look beautiful. Again, these crystal clear corneas, when you're experienced, don't get discouraged when they're still cloudy in your early training curve as you're doing this. But you do get these really lovely crystal clear corneas. Your follow up could be largely the same that it is with phaco. You're looking for the same type of issues, right? At post op day 0 or 1, you're looking: are my wounds sealed? Do I have any signs of TAS? Does everything anatomically look the way it should? And you're doing the same thing for the SICS case. Then your next visit, looking for signs of inflammation, anything that isn't healing normally. And that can be done, 5 days, 7 days, 10 days. And then after that, let's check in and see what this refraction is going to be. SICS does induce some astigmatism, again, with a large wound, but because it's a tunnel, it's much less astigmatism induced than if you were doing a large, clear corneal incision. You say you were extending out for a conversion case. So optically, they can have some really nice, consistent results, similarly to phaco.
What are some complications that are unique to or seen more often in M6 compared to phaco? You did mention that it can induce more astigmatism compared to phaco. Do you think of any other complications that might be unique?
Yes. So we've all done cataract surgery. Again, if you're 100, 150 in, where you've had iris starting to come out of your phaco wound. There's a few variables, things like Flomax, floppy iris, but the most consequential one that I see is a really short wound. Because what you're doing with the short wound in phaco is you're basically entering in at the level of the iris. So the iris has direct access to that, and the iris evolved in a way to clog openings, and that's what it's trying to do. So, you've got a 2.5 millimeter incision and the iris keeps coming out. That's really frustrating. All right. So now imagine to do an SICS wound properly, you need to extend the internal area of your wound to 8, 9, 10 millimeters. The way you do that is you make a blind pocket initially. You make a funnel shaped wound, 6 millimeter opening to the outside, and then you tunnel partial thickness, but you widen out as you enter into the clear cornea. So now you've got this tunnel which enters into the clear cornea by about half a millimeter into clear cornea all the way across. So your next step, you've got to take your keratome, you've got to go and incise in the very end of that pocket. And if you happen to accidentally enter the eye and make a short wound, enter at the level of the iris, and then heaven forbid you extend that to the right and left, now you've got a gaping 8, 9, 10 millimeter opening. And that iris, it loves nothing more than exiting the eye at any and all infusion into the eye. It is so frustrating, and it actually is very high risk. People have had entire irises removed, unfortunately, not just an iridodialysis, which is something we fear, but actually removing the lens, actually engaging the iris and pulling the entire iris out of an eye. So that's something, thankfully, in phaco surgery, if somehow you manage to remove an iris, I can't imagine how, but that is something that could happen in M6. Outside of that, M6 does have some more challenges with the variability in the rexes. It can be a little bit more difficult to identify a posterior capsule rent at times in M6, just because after you remove the main nucleus of the lens, you've got all this cortical material there. And again, as you're peeling that away, it's just a little bit less of a consistently closed system like you have in phaco. Outside of that, what whatever complication you can have with phaco outside of a wound burn, mind you, you can really find your way to have an SICS as well.
I think you touched on, a very scary case, like you mentioned, and really speaking to the importance of creating a good wound. And so let's talk about times when we need to convert to M6 or intracapsular cataract extraction intraoperatively. What are some scenarios that you think about, and what tips would you have for beginner surgeons who find themselves in these scary situations?
Yeah, tips for very early surgeons: recognize that most of you are going to be practicing in a place where you're going to have retina available in some form. And kind of being a hero and engaging in the eye in ways that aren't safe, such as a lens that's dropping and trying to retrieve it, that's something that presents a lot of risk to the patient. Now, if you're operating in a setting where there is not a retina backup or anything that this patient would reasonably get to, then it's actually quite reasonable, if you have a lens that is tilting back into the vitreous, to do something like posterior assisted levitation, or do other techniques where you can try and leave that lens up, or rather keep that lens up. For you as a surgeon, it's really going to depend on your skill set, when you might want to convert or not. If you've never seen an SICS surgery, you may never want to convert. You may just want to shut the eye and refer to retina, or refer to someone who is familiar with that technique. But if you do have some experience with it, with delivering lenses whole, then tips are going to be: you can extend your clear corneal wound and then place sutures. That's the traditional extra cap. That's great, particularly if you're a cornea surgeon doing transplants. That's not going to give you any angst. But if the last corneal suture you threw was a year ago, that's going to be a long, difficult challenge for you to do. You can sew your phaco wound up and just rotate 90 degrees and go either superior or temporal and do an SICS wound from there. Indications for that: a lens that is just so dense, it's clear you're going to traumatize the eye potentially beyond the endothelium's ability to safely regenerate itself. That's one. Another, particularly for something like an intracap, where you might be delivering the entire bag whole. This was our case recently in Tanzania, operating with my partner, Dr. Frank Sandy. This was a lens that was effectively, once we were in there, had zero zonules, dark brown, brunescent, and with some viscoelastic elevated it up. But the entire lens we delivered out through a manual small incision wound. There was no vitreous in the AC. You do the typical things: vitreous stain, put in some Myacal, Myostat. No vitreous whatsoever. You can then place a lens, leave someone aphakic, do an AC lens, do a scleral fixated, iris fixated, any of the above options for a patient like that.
Great, great pearls. And so going back to our patient with a very dense nuclear cataract in the right eye and a white cataract in the left eye, and your exam doesn't show evidence of significant zonular compromise, and the eyes dilate to 8 millimeters, what cataract surgery technique would you recommend?
I love it. Such a good case. Hard dense brunescent. I'm going to say that it's like borderlining on kind of something that's really black, where it's clear, clear. This isn't going to be phacoable. I'm going to do SICS. If I'm a really great SICS surgeon, I'm going to do an SICS on that brunescent lens, because again, it's just such a beautiful, elegant technique for those lenses. The white cataract, it's the box of chocolates you never know when you're going to get. It can be entirely milky and just vacuum out. You can have the hardest, densest lens you've ever found sitting there just underneath the surface. You really don't know. So a beautiful technique I love doing is just starting through a paracentesis. Paracentesis, lidocaine with epinephrine or phenylephrine, put in some stain, of course, put in some viscoelastic. Then through your paracentesis, enter into the AC. You aspirate if it's intumescent, and then you just kind of see, what am I dealing with? Is this a giant lens that you just couldn't see, that is dense and hard? All right, if it is, finish your a large capsulorhexis through your para with a micro Utrata. Then then just turn and make your SICS wound and deliver it whole. If it's pretty soft and phacoable, carry on. Make your regular size rexus. Make your phaco incision, proceed with phaco. Every so often you're going to be wrong and realize you should have done one or the other. But again, white cataracts, they are so much fun because you really don't know what's going to be just underneath.
I love the chocolate box analogy. I'm definitely going to use that in the future. And yeah, there's some of the most satisfying cases, and I think one of the cases that teaches residents the most. So thank you for those pearls. And you did mention a little bit about training programs that help people, especially starting their careers, incorporate these into their practices. What specific opportunities can they pursue in order to get better at M6, or if they are an M6 surgeon, to learn phaco?
The best way to learn manual small incision cataract surgery is to become a student of it, which means you need to start watching videos. You need to get a little textbook, whether that's an online one or one that you walk around on the floor at AAO or ASCRS and you pick one up. But you need to learn and become a little bit of a student of it. Learn about its history, how it evolved, how it's done, so that theoretically you know what you need to do. Then you're going to be really well prepared as you come into a wet lab. And you just need to start in a wet lab. Start with the AAO or ASCRS, or the Global Ophthalmology Summit as an amazing wet lab where you can come, be taught by mentors, and really work on some of the techniques that are just different from phaco. So many of the techniques are really similar. You're just modifying what you know. Some of them are entirely different, like this large scleral tunnel. And then after that, you need reps, and you need mentored reps to be safe. And I use this analogy all the time. When I finished residency training, I could have gone out and done some strabismus surgery. but I wasn't really that well trained in doing it on my own. And along the way, I would have taught myself how to do it, but I would have left a lot of cross-eyed kids in my wake as I learned how to try to figure out how to do it. And it's the same thing. You will break bags, you will cause trauma, you will have complications, you will have retina detachments, you will have endophthalmitis if you're trying to do this all on your own. If you can find someone who can, just like in residency, can be the one to stop a problem before it happens and make sure that you're taking these graduated steps forward, you're going to do better. The patients are going to do better. And in the end, you're going to frankly be a much better surgeon having had that. Now, that's the easy thing to say. The hard part is to find it. The best community out there is at the Global Ophthalmology Summit. That is where you can meet with these adept SICS surgeons who have learned this. They're doing it around the world. And that's really going to open the doors for you to find pathways to go and train at places like Aravind Ali Prasad, Tilganga, or now actually many places across Africa, Central, Southern America, where they're doing enough of these cases with some experts that you can be taught. And it would just be remiss if I didn't mention there's some really great SICS simulators available, some virtual reality simulators. Help Me See has one, and there's some others that are in development by Orbis that, again, just like in residency, you're just trying to shorten and shortcut that learning curve a little bit to where the first time you're sitting down with a patient in front of you, you've got some experience under your belt.
We really appreciate the input, on a lot of the opportunities that you've mentioned. Um, I know you also have a great global ophthalmology fellowship. There are different global ophthalmology fellowships available for trainees, especially for residents who are interested in pursuing this further.
I'll just say this: so many of us, we read our personal statements. We can go back and read them. Global eye health, underserved populations. These are reasons we go into medicine, and unfortunately, the system is such that by the end, you go from 90% touching on really, really wanting to be engaged, and at the end of training, oftentimes the only thing we can think about is like, I just need to get a job. Like, where am I going to work? Who's going to like me enough to hire me? And it's this profoundly like missed opportunity where our global ophthalmology fellows that are taking this time, whether it's a 6-month fellowship, a 12-month fellowship, they're flexing into this thing that we really brought so many of us to the table, particularly for ophthalmology. And then you're learning how can the highest level of care be provided in some of these incredibly low resource settings. And of course, you learn SICS along the way. But more importantly, you really learn how can we be a part of a solution of global blindness. There's 20 million blind in the world right now, and our best estimates, some generous estimates, are we're going to go from 20 million cataract blind to 50 million cataract blind by 2050. SICS is absolutely a part of that fundamental equation. And the more of us that know how to do it, the more of us that are versant in global eye health, the better we can decrease that. In my view, eradicate preventable, curable cataracts blindness from this planet.
Wow, that's so powerful. Thank you so much for sharing all of that information. I'm very inspired, and I truly believe that our listeners are too. So let's summarize what we've learned from Dr. Pettey. Non-phaco emulsification cataract surgery may be the procedure of choice for cases where phaco is not deemed safe for the eye. Intracapsular cataract surgery is a historic procedure, though still performed, as we just heard, that consists of removal of the entire lens, capsule, and the zonular complex with higher likelihood of complications. Extracapsular cataract surgery may be the best option for patients with dense cataracts, cataracts in the setting of very poor capsular support, or damaged corneas that may not permit adequate visualization. The procedure consists of creating a large scleral incision that allows for the removal of the intact lens nucleus. And M6 is a variation of the extra cap procedure that consists of a smaller incision that typically doesn't need sutures. Key pearls that Dr. Pettey talked about include creating an adequately sized and well controlled scleral wound, a large capsulorhexis, and ensuring a good hydrodissection. And this is an important skill for cataract surgeons to learn who want to practice in low resource settings, as it can be performed at a fraction of the cost of phaco and has comparable safety and visual outcomes to phaco. In cases when intraoperative conversion to M6 is needed, it is important to create a new wound through a scleral tunnel or to potentially enlarge your corneal wound. Not be afraid to leave the patient aphakic and prioritize safe surgery, which may mean closing up and coming back to fight another day. Anything else you would like to add, Dr. Pettey?
I just want to thank you. Thank you to everyone who takes the time to educate this community of ophthalmologists. And it's not lost on me how many trainees might be listening to this. And we appreciate the work that you do for ophthalmology, and it is so worth it. The career that we have chosen is something that continues to inspire me, and I feel lucky every day to do it.
We appreciate educators like yourself who dedicate their time to teach us and to grow the next generation of ophthalmologists. So thank you again. And Dr. Pettey, before we end the episode, I ask all of my guests a question. My question for you is, if you could go back in time and give your younger self one piece of advice, what would it be?
This question is a real challenge for me because I've loved so many aspects of my career. And I feel like every time I've taken a step towards something that I always wanted to do, whether it was be involved in teaching, whether it was be involved in global eye health, I've been rewarded in spades. So I would say don't be afraid to take a little step in a direction that feels a little unsafe, that is a little bit off the beaten path. If it's going to be pursuing something that uniquely speaks to you, that's where you're going to find that filling of your cup every day is engaging in ophthalmology in a way that again speaks to your soul and speaks to what you wanted to do and the reason you went into ophthalmology in the first place.
I love that. I think that's very inspiring. Thank you so much for that great answer. And Dr. Pettey, thank you for joining us on this episode of the Pupil Pod.
My pleasure. It's the best. Thanks, everyone.
And thank you to our listeners. See you next time on the Pupil Pod.